I have the distinct honour of inviting a fantastic cardiologist to speak, Dr Tim Sutton. He brings deep expertise and a growing global perspective to the field of cardiac amyloidosis. Dr Sutton is a general cardiologist, but with a focus on echocardiography and heart failure. His clinical interests have led him into the specialised and increasingly vital world of cardiac amyloidosis. Dr Sutton has enriched his experience through educational exchanges at the National Amyloidosis Centre in London and the renowned Boston Centres. He serves as the New Zealand representative on the cardiac subgroup of the Australian Amyloidosis Network and has played an important role in shaping the Australasian guidelines for the investigation and management of transthyretin, or TTR, amyloidosis. Currently, Dr Sutton is the principal investigator in 2 ongoing clinical trials exploring treatments for TTR amyloidosis. His dedication to research, clinical care and education is helping advance how we understand and manage this condition in New Zealand and beyond. Please join me in welcoming Tim to the stage with a big round of applause.
Thanks for the introduction, Siren. Kia ora, everyone. Hello, hopefully there's people out in Rotorua. So I don't know if you guys know, but the Cardiac Society meeting is this weekend. So this is being live streamed to the Cardiac Society. So hopefully there's a room full of cardiologists out there learning as well. I'm afraid we're competing with the plenary speech, so I'm not sure there'll be many people there, but hopefully someone will be tuning in. And so what I'm talking about, please chip in and ask questions because, like Jamie said, there's going to be medical stuff. I've tried to keep it as broad as possible, but if I'm using acronyms, abbreviations you don't understand, please chip in and ask as I go along. Right now. So hopefully, cool. So first question, what is amyloid? So amyloid is something that you see down the microscope. So when someone takes a sample of tissue, they put a stain called Congo red on the tissue, and rather bizarrely it makes the amyloid tissue shine up and it's apple green. So this was something as a medical student that fascinated me. We were told about this in a lecture, the last lecture before Christmas. So that the fact that you could put red and green together on a slide just before Christmas was pretty interesting. And the whole thing is with amyloid, it's a descriptive phrase. Now, if you're told you've got amyloid, it doesn't mean you know the type. What someone has seen is this down the microscope, and that can cause all sorts of different diseases, as we'll talk about, and it affects your body in different ways depending upon where the amyloid fibrils go. And there's all different phraseology that's used. So there's AL amyloid, and that's the one that's related to light chains, and you can either produce those from your bone marrow, and that's what Rajiv will be talking about after me, or it can be produced from a single area, and that's localized AL amyloid, and the treatments of the two are different. The one I'm going to spend all my time talking about is TTR amyloid, and there's 2 types of that. There's either the wild type one, which is more common as the years go by. It's a disease of aging. And there's the genetically determined one, which is what Aubrey had, Jamie's husband, and that affects people at a younger age and often affects the nerves more. And I think Duncan's going to talk about as well. There's AA amyloid, and that's associated with chronic inflammation. So when you have low-grade inflammation in the body, you produce this amyloid A, and that's something that was much more common 15, 20 years ago, and it's associated with chronic infections, things like inflammatory bowel disease, with diseases, rheumatological diseases like rheumatoid arthritis. But because the treatments have got so much better with drugs called biological agents, this is becoming much less common and is really disappearing in Western countries from the amyloid spectrum. And then there's the rarer types, which aren't so necessarily cardiac focused, but they may cause kidney problems. And so here we go. So what exactly is TTR amyloid? Why do we have it in our body? And this is where the name comes from. It transports thyroxine and retinol, and that's simply where its name comes from. It's TTR, and retinol is vitamin A. So if any of you are on the treatments, like in the gene editing trial, you need to have your vitamin A because you're not got a carrier in the body, so you get a supplement. But it carries about 15% of the thyroxine around the body, so if you lose your TTR, you don't end up losing thyroid function. And this is what it looks like. So, I don't know if we've got a pointer, even better. Yeah, so there's these things called tetramers, and they're identical, and there's 4 of them. And the thyroxine sits in the middle, holding it all together. So that's how TTR is held together. And when you got these binding chains, you got this is what the drugs try and mimic. But this one here is an abnormality in a gene. And if you have this gene, your TTR is less likely to unfold. And some of you in the room will be on acoramidis, and acoramidis was designed specifically to try and stabilize this site. Now, if you have this genetic mutation, you live longer. So I suspect the makers of acoramidis are hoping that if you have acoramidis, you mimic that and live longer. But we'll only know with time, because that would be a true anti-aging drug. But these mutations here are the commoner ones that you see. This one comes from Portugal. Sometimes it affects younger people. This one's more common in Afro-Caribbean descent, and 3% of people of Afro-Caribbean descent have amyloid, TTR amyloid, as a result of this gene. And this one, is, I guess, a reflection of colonialization. So this originated in Portugal, but there's big populations in Malaysia and the Far East, because the Portuguese colonized in that sort of area, taking their genetic diseases with them. There's an Irish variant as well, so all these different genetic variants can be found in different parts, and they can define where you come from. And here you go, you can see there's multiple different abnormalities that can be present. That's your thyroxine there. So there's all sorts of different kind of misprints of your DNA that can result in the TTR not binding properly. And that's if you've got the genetic type. And like I say, what happens is your tetramer is there, you've got an abnormality so it doesn't bind so well, the TTR unfolds, and instead of reforming like this, it misfolds, and that produces the amyloid fibrils. And that's a process that's going on slowly over many, many years. And the amyloid is deposited in the tissues and starts to produce an effect. And the one we're going to be talking about, of course, is the heart. I say it carries vitamin A. It's 15% of the thyroid pool. Where does it come from? It comes from the liver, so it's almost uniquely produced in the liver. Some is produced at the back of the eye, and there's a little bit produced in the brain as well. But it gives you an organ you can target for treatment to try and help switch off production. And if any of you ever measure, the TTR level, the normal level is 20 to 40. We don't do it very often because it's expensive, but in the trials, it's one of the things that's looked at, as I'll show you. And how common is TTR amyloid? One of the challenges, as I'll come back to later, is it's deemed a rare disease. And why is it a rare disease? Now, how do we go back? Cool. Back here in 2000, which is when I just started as a cardiologist, there wasn't a lot of diagnosis of TTR, as you can see. The number of new diagnoses was tiny. And wild type, which is the red one, there was very little wild type amyloid diagnosed. And why was that? We didn't have good diagnostic technologies, and we didn't have treatments. So people would have heart failure, they'd be treated, and that's all we could really do back here. And there was a huge change, treatment-wise in treating heart failure. Then as the years went by, cardiac MRI started to become more widely available in about 2004, 2005. And one of the reasons we do cardiac MRIs is to look and see why a heart is thickened. And it gives you information if people have got a condition called hypertrophic cardiomyopathy, which is a genetic condition. If you've got lots of scarring, that means the risk of abnormal rhythms is higher. And what was happening was people were having cardiac MRIs, and a pattern that wasn't hypertrophic cardiomyopathy was suddenly being recognized. And that's where increased growth of awareness of amyloid was starting to increase. And then suddenly these scans, the one I put there is DPD, but they're nuclear scintigraphy, so that can be a PYP scan. Use of these was beginning to take off. And I'll show you a few pictures of a DPD scan, but that's a really sensitive and specific test for TTR amyloid. It grew globally. And this 2011 here is when I first met Simon. So I was at the Amyloid Centre, and that's where I first heard about this scan, and it was progressively taking off over the world. And you can see here, suddenly DPD scans have become much more widely available, and there's an exponential increase in the diagnosis of TTR amyloid. So TTR is not truly a rare disease. It's a disease that hasn't been identified or diagnosed due to a lack of recognition, awareness, and kind of access to investigation. And as I say here, most people are not diagnosed with this during lifetime. And we know from the past, in Scandinavia, they did an autopsy series, and 25% of males have amyloid in their hearts when they over the age of 80 on post-mortem. So essentially, it's a natural part of the aging process, but it depends at what point it affects you as to what impact it has on your well-being. And this is data from this year, basically, looking at the V is the variant genetically determined and WT is the wild type. And you can see that the numbers are not high here, but they're still significant. The problem is we've not got any data or much data from either Australia or New Zealand, and that's something, at a personal level, I hope to try and get a database up and going and be involved with the Australians who are doing the same as well, so we can produce regional data for Australasia, because being part of a bigger group, hopefully you can bring pressure to get the treatments that I'm talking about. There has been information, here we go, and when you go looking, so this study here is in Spain, and this is what amyloid looks like in your heart. The heart shines up and your bones aren't so well seen. These guys took all DPD scans that were done in people over the age of 65, and 1 in 50 people from a random group, so people are having these scans either looking for arthritis in joints, they're looking for infection in artificial joints, or they're looking for prostate cancer, because this is the scan that's routinely done looking for prostate cancer. 1 in 50 people had an abnormal scan showing amyloid in the heart over the age of, or males over the age of 65. And when cardiologists made referral, the hit rate was about 20%. So, the awareness is increasing, and this is what's there in the population. 2% of males at 65 walking around the street probably have this condition and don't know. And if you look at specific populations, basically, let's say we've got the autopsy, like I mentioned, people who have aortic stenosis, so that's a narrowed heart valve. It depends where you read, but about 8 to 10% of people who have new heart valves put in have amyloid in their heart. And it's not necessarily been identified, but it means if you do have that, the response to the treatment may not be so great. You may still be breathless. And like I said, this was where MRI came in. People were thought to have a genetic condition, hypertrophic cardiomyopathy, but around 7 to 10% of them who are male actually have amyloid as the cause of a thickened heart. And it's only as MRI grew that was recognised more. I'll talk a bit more about this HFpEF. So this is people who've got a heart that works properly, but who get fluid retention over the age of 65 in hospital. 10 to 15% of them have amyloid in their hearts. And people who have pacemakers, it's common. And the one that is really of relevance is if you have carpal tunnel syndrome. Now, those of you in the room who have TTR amyloid, almost all of you will have had surgery for carpal tunnel syndrome. Within probably 5 or 10 years before the amyloid was identified in the heart. So it should be a red flag if someone has carpal tunnel syndrome, especially over the age of 55, 60. So when people are younger, it can be occupational. So it's people who are builders. You're using things that vibrate your hands. You're putting a lot of force through your hands. That causes inflammation. You can explain the carpal tunnel syndrome then. But generally, if you're 55, 60, you're getting the younger people to do that. And if the symptoms develop, and recently there's one of the team in London, they sent off tissues for everyone having carpal tunnel surgery, and I think it was about 30 or 40% of people have TTR amyloid in their carpal tunnels. So it's a condition, if you go looking for it, you can find it, but routinely, if people have carpal tunnel surgery, they don't typically have material sent off, and for us making a diagnosis, it's really useful to have that available and to think about it. And now we've got treatments that can help if you can access them. You can change what happens by knowing earlier. Cool, so any regional information, this is from Australia, and it's similar to in Spain basically. They took all comers who were having a bone scan and found that 1 to 2% of males had amyloid in the heart, just at random on bone scans. It's more common as you get older, not quite like in the post-mortem series. And the other thing to notice here, this is the ratio, it's about 10 to 1 in males to females. So it's unusual to see TTR amyloid in females in their 60s and 70s. Some people do get it, but it does come a bit more common as we get older, and you can see the gap narrows, and that's the disadvantage of being a male, is you don't live as long, so females catch up. So that's why the gap is narrowing. And so from this, there's an estimate that 33,000 Australians over 65 have TTR amyloid. And as I'm sure Simon will tell you, that's not the number that are diagnosed, but that's an estimate going from the information they've got there. And if you extrapolate that to New Zealand, it means there's about 10,000 people in New Zealand with TTR amyloid. We've only touched the tip of the iceberg there, and this is, I'm talking specifically about cardiac amyloid. So there is a huge unmet demand, and that's where beaming into the Cardiac Society is good, increasing people's awareness and clinicians. Because as we'll come back to later, there is a delay in diagnosis. And what happens with the disease process? Like I said, you've got your TTR unfolding, and the TTR unfolds and then it refolds and misfolds, and the wild type TTR tends to form linear strings, whereas the genetic type forms these spherical TTR fibrils. And these gradually build up in the tissues over time. They get deposited, and the problem is this is going on over tens of years. And at some point it reaches a point where you get symptoms because the plaque is starting to in fact impact on whatever organ the TTR is building up it. So that can be the nerves, the carpal tunnels. It can be in the tendons as well. And what I'm going to be mainly talking about is the heart. And you can either have it because you've got the genetic abnormality, so the glue that holds the TTR together, it just doesn't bind properly because you've got two jigsaw puzzle pieces that won't interlock properly, and that creates weakness. But as we get older, this is what's changing. You require the most energy, but as we get older, everything doesn't work quite so well. You have more oxidative stresses inside your body just as part of the aging process and abnormal metabolism. Heavy metal ions can impact on TTR, and all of this results in weakening of the TTR itself, and it starts to misfold, and your body clears abnormal proteins through a process called proteostasis, but as you get older that process is less good. So it's a constant dynamic sort of process, and you're clearing what you don't need, but at some point your body's producing more than you can actually clear, and that's where you start to get deposition. Sorry, this is a bit murky. I borrowed it from a talk I went to 2 weeks ago about this. But that's how disease progresses. You're exceeding your body's ability to cope. And the body's an amazing thing. It keeps us functioning. But at some point, you do start to end up with a problem. And as I said, it can build up in all sorts of organs. The carpal tunnel is the commonest place that we see it, and that typically predates identification in the heart by about 5 to 10 years. It can build up in the spinal column in a ligament called the ligamentum flavum, and the spinal cord is a tube, and there's the ligament at the back, and what happens is the ligament builds up and the spinal cord gets a bit distorted or compressed, so it can cause discomfort in the legs when you walk. And that's not an uncommon occurrence. It can be picked up on MRI, or if a surgeon's doing an operation, they can take tissue. The one I love is the biceps tendon. So I guess in the room we've got a few Popeyes. So what happens is, this is, you can see here that there's, when people tense their muscle, the muscle looks big because normally you have two heads to biceps, and you can see one here has gone. You usually don't lose any function with this, fortunately. Often people don't know it's happened. Those of you in the room that have seen me and remember being slightly bemused why I was getting you to flex your biceps when I examined. Why is a heart doctor obsessed with my biceps? This is present in about 50% of people with TTR amyloid if you go looking for it. So to the cardiologist out there, if there's any, I'd encourage you to get your patients to flex their biceps, because if you don't, you won't see this. And if you see it, you have to prove your patient doesn't have TTR amyloid. Because if you do have it, almost certainly that's what they've got in the absence. Sometimes it's a result of trauma. This is what Super Rugby players do and that sort of thing. But in the absence of trauma, almost certainly you've got TTR amyloid, and you really have to, especially if someone's seeing a cardiologist, you've got to prove that's not what they have. If you've got the genetically determined type, you can get these things, but it also builds up in the nerves. And I don't step on Duncan's toes, obviously you get peripheral nerves and autonomic nerves. And that's my understanding of neurology. Duncan will build on that a wee bit later on. So what are the cardiac terminologies I'm going to be using? So heart function, the heart fills, and the heart squeezes. So that it's relatively easy to understand the concept of a heart squeezing, and that's how blood is circulated, and that's a pretty easy concept. So it's like firing a cannon, but the problem is if you don't prime a cannon properly, it won't fire properly. And that's what diastole is. So that's the heart filling. The filling process of the heart, the top chamber, which we've got down here, the atrium squeezes and fills the bottom chamber. So if the pressure in the heart is high and this isn't working properly, your priming mechanism in diastole is not so good. So as we'll talk about, usually the heart squeezes okay with amyloid, the firing is okay, but the priming process is the problem. Other bits inside the heart, so there's the heart pump, there's the heart electrical system, and we've got a structure inside your heart. Your natural pacemaker sits here in the right atrium, and there's all this electrical wiring. The electrical skeleton of the heart carries electricity down to the bottom pumping chambers of your heart, and then the current spreads through the atrium as well. So you can have amyloid buildup anywhere inside the heart, and it can produce abnormal patterns on the ECG, and if it affects this bit here, that's the electrical communication between the top and the bottom pumping chamber. It can cause heart block, and people need a pacemaker. And that's a not uncommon occurrence, and that's why we do things like ECGs. You're looking for patterns to suggest there's abnormal electrical conduction. And when the atrium is affected, you can get erratic heartbeats like atrial fibrillation, which about 50 or 60% of people with amyloid will get. And then there's your heart arteries on the outside. Typically, people with amyloid often don't have heart artery disease relating to it, but the heart muscle is thickened and you can get amyloid in vessels. So you can get angina, which is a tightening in the chest when you walk, with what we call unobstructed heart arteries. The flow down the arteries is okay, but it's just that the blood getting through from the actual pipe itself into the muscle isn't so effective because of the amyloid. So that's the different things we're talking about when we're thinking about heart disease. So there's not too much you have to know to be a cardiologist, really. It's just a little bit about this, basically, which is what we do. Now, this video was playing. I stole this from the National Amyloid Centre website. You can see here the amyloid's unfolding, and then it disappears off, and that's what we've got here. And how that works in the heart. So the heart is all these sheets of muscle that are all interlocking like this. And the amyloid fibrils get deposited in between the heart muscle. So that means the heart can still squeeze, but it's not squeezing effectively. It's losing its elasticity. So the function of the heart in terms of squeezing is maintained, but the elasticity of the heart is affected. So that's how the disease develops. And this happens over years and years and years, like I said. And how can it present? Like I say, it can be an incidental finding. Sometimes it's found on a tissue sample, completely by random. Sometimes it's seen on a bone scan, like we said. Sometimes it will produce symptoms of heart failure. So heart failure is a symptom where all it is, it means you're getting breathless with an exercise, you're getting fluid retention. And the hallmark of this condition is what we call restrictive cardiomyopathy. So with the dynamics of the heart is stiff. So if you imagine you've got a bucket and you've got a bath and you've got to empty that bath, but you've only got a bucket that can't change, the only way of emptying water is with your bucket. That's speeding up the process. You have to empty faster. And that's how this works. So when you're sitting still, you can keep emptying water out quite happily. when you exercise, your heart speeds up. And at some point, the heart says, well, I can't get enough blood around the body to meet what you need. And that's when you get breathless and feel a bit tired. And that's what happens with this process, is the heart has a limited ability to increase its output because of the way the physiology works. And if your heart goes too slowly, and that's with drugs like beta blockers, if any of you are on them, you feel worse because you're emptying that bath slowly, and that's not what your body wants. It wants your heart to go faster. And we use the terminology heart failure with a preserved EF, and that just means the heart squeezes okay, and that's against heart failure with a reduced EF, so the heart's not squeezing very well. And the arbitrary figures we've got here, this is above 50%, and this is below 40, and there's a mid-range bit. Some people present with arrhythmias, like I said, the electrical system goes on the blink and you faint, or you can have irregular heart rhythms like atrial fibrillation, which is quite common. And people will often present with angina or have a raised blood test called a troponin, not caused by a heart attack or blockages in the heart arteries. And what tests do we do? Well, we do these things, the cardiac biomarkers, and the troponin is a test if someone has a heart attack. That's where it's used in the hospitals. But often the troponin is elevated and not caused by a heart attack, and that's one of the typical findings in both AL and TTR amyloid, that there's a stable elevation of the troponin. And people will often have an angiogram and told there's nothing wrong with their heart, but there is, because the troponin's high. It's just not caused by the heart arteries. This is the heart happiness hormone, I call it, basically. It's produced in response to stretch on the heart. What it does, if you produce it, it makes you pee more. You lose a bit of sodium. So it's your body's way of compensating for the heart being under pressure. And it will climb before you feel unwell. And it gives you an idea where the heart is at in terms of how it's feeling. And it guides us on treatment, basically, and how the heart's coping. And then the EGFR is a measure of your kidney function. And if the heart's struggling a wee bit, often your kidney function will get worse, and that makes everything worse. And as the heart gets better, these two will improve. So having those blood tests done regularly helps us monitor how people are, how you're responding to treatment, and whether things are changing over time. And as Rajiv will talk about, when this is specifically to my cardiological colleagues, you must rule out AL amyloid. And the way AL amyloid has to be ruled out is doing serum and urine immunophoresis. In Auckland, I request this numerous times. I get serum electrophoresis. I have to send an email saying I didn't ask for that. I asked for immunophoresis because this is the gold standard. This is what guidelines recommend. I can't request this in Waikato. I'm a cardiologist. Only hematologists can request this test. I tried to organise it and got a polite letter telling me not to do that. And we can request plasma light chains as well. So, and if you were to ask me what's the biggest gap in terms of the simple diagnostic pathway, this is the thing that very rarely is done correctly. There's often one of the three missing, but it's something cardiologists and registrars you need to do. And if you don't quite understand, that's where you call your friendly hematologist, because you get these light chains back, and often we find that the light chains are what your bone marrow produces, and the Kappa one is often a wee bit high. And that's not uncommon when your kidney function isn't so good. So there's a range that's been generated to guide us as to when to worry. So if you're uncertain, you ask your friendly hematologist, do they think this is a problem or not? But most of the time it is related to renal dysfunction. But Rajiv will talk a wee bit more about that. And for those of you that are going in trials, this is something that is really drilled down on. We do ECGs. So this chap looks quite happy to have an ECG. For those of you who've never seen an ECG, it's basically just doing a heart recording, and all it does is look at the electrical flow through the heart. And when we're looking at ECGs, you're looking for the absence of normality. So that's what you spend your whole time at medical school doing, is learning what's normal, so you can tell if something is not normal. And because the amyloid can affect all bit of the heart, this is the atrium we see. The heart muscle, if you've got hypertrophy, which is when the heart muscle itself gets thicker and bigger, it produces a pattern on the ECG. But with amyloid, the heart muscle isn't hypertrophied, it's got amyloid spreading it apart. So the ECG tends not to show hypertrophy. So if you're looking at an ECG and we don't see LVH on an ECG, but we see it on an echo, that should make you think, could this be amyloid, rather than just saying it's hypertrophic cardiomyopathy. You can see these things, pseudo-Q waves, they're what we see in heart attacks. They're more common if you've got AL amyloid, and you can see electrical flow problems as well. So ECG is always our initial starting tool. It's the simplest thing to do. And for cardiologists out there, it's really important to look for change over time. And this chap was a patient I looked after a few years ago. He had a normal ECG here. 3 years later, things were changing, and he had AL amyloid. We diagnosed it off this and what was seen on his echo. Echo is our go-to test after an ECG. It's a simple way of looking at the heart. And on an echo, this is what we see. There's the atria down here, so those are the collecting chambers. This is where your natural pacemaker is on the right side. There's your pumping chamber, the left ventricle, and there's the right ventricle there. And these are heart valves. There's the mitral valve and the tricuspid valve. So this is one of the standard views on echo, basically. But you can get beautiful pictures, and it gives us an idea about how the heart is working as a pump. And it's our go-to test to assess that. We can look at how thick heart muscle is. We can look at whether the chambers of the heart are bigger. And typically with amyloid, people often have big collecting chambers or atria. The valves can be a bit thickened, and the septum, interatrial septum, this bit here, can be a bit thickened. So anyone who's got amyloid in the room will have had one of these. And this is what a thickened heart muscle looks like. Normally this is about 1 centimetre or under. We see people's septums get up to about 2.5 centimetres, so it can be 2.5 times the normal size. And because it builds up so slowly, people don't notice they're feeling less well. And the right ventricle can get thicker as well. So this is the right heart, and that's the interatrial septum. So on echo, always the first thing we look at is the moving pictures. And if any of you have ever read your echo report, and for the cardiologists who report echo out there, with amyloid, the apex of the heart, which is the top bit, squeezes better than the base of the heart, the bottom bit. And you can see it here. That is squeezing well, but that's squeezing badly. And then if you cut down the heart, this one is squeezing okay, and this one's barely moving, and that's going from here to here. And this is what's called base to apex contractile gradient. And if you've seen the people talk about an apical sparing or cherry on top strain plot, that's what that looks like in moving pictures. So if we see that on an echo, immediately you're thinking, could this person have amyloid? So it's one of the clues when we're reporting echoes that gives us an idea. And here we go, this is the strain pattern. So you get this cherry on top. So it just looks like it hasn't an ice cream, the cherry on top, basically. So LV strain imaging sort of encouraged the sonographers, cardiology trainees to really try and do it on every echo they do. But if someone has a thick heart, this should be done as routine, because if you don't do it, you don't see it. And not doing it is not a reason not to see it, basically. There are other causes of this pattern, so it happens in people who've got kidney disease. So if you see this pattern, it doesn't automatically mean a patient's got amyloid, but the clinical suspicion should be high. And we can see, over time this can change. And then we look at the elasticity of the heart, and that's the filling of the heart. And this is someone's echo over 7 years. And if we look at the strain plot here, this is what a normal one looks like. This is 3 years later. You can see the pink is beginning to appear, and the numbers are beginning to drop. And this is when I saw them here. So over time, they'd had a progressive change that showed the amyloid was building up in their heart. And when we look at measures of elasticity of the heart, that's what we see here. And we can see the elasticity of the heart was gradually changing. I won't go into bore you with the specifics, but that's what you can see over time. So if people have had serial echoes, certainly for people who report echoes, it's important to go back and look for serial change over time. Because if you see change, you have to explain why it's happening and try and identify what the underlying process is. And this is the key to diagnosis. So this is the most important pathway for the cardiologists, cardiology regs out there. So we suspect because of an echo that someone may have amyloid. They've got Popeye biceps and they've had carpal tunnel syndrome. The light chains are normal or the light chains are abnormal. If the light chains are normal, we do this test, a bone scan. And that's your next test. You don't need a cardiac MRI to diagnose amyloid. There's a huge push to say you do need it, but you don't. You just need this DPD bone scan. And what a bone scan does, you're given a tracer, and this is a normal one. It's all picked up in the bladder. There's a bit of arthritis and stuff, but you can't see the heart just here on this scan. And what happens over the scan is this is an abnormal one. This one's mildly abnormal and a bit non-specific. But here we've got the bones and the heart at the same intensity. And here the heart is essentially the only bit of the body other than the bladder that's got the tracer in it. And this is highly, highly suggestive of TTR amyloid. So those of you that have got TTR will have had a bone scan, and this is what you're looking at. And for the people requesting them, it's really, really important. You don't just get planar images. That's just where the camera imaging's done. You must get SPECT, so you know the uptake is inside the heart, which we can see on this scan here, and it's in the right ventricle and in the left ventricle. Because you can get what's called a false positive scan. In other words, the scan's not real, and that can be because the trace is actually inside blood rather than in the heart. So it's really, really important to request SPECT-CT. Most of the places in Auckland do this, but every now and then someone will just have a planar scan. But if you've got a grade 2 or grade 3 positive scan, your light chains are normal, that's enough. You've got TTR amyloid. You don't need any other testing done in terms of investigations. If the scan is normal, but we still think you might have amyloid, that's where MRI has a role, because there's some amyloids that a DPD scan won't pick up. They're not TTR amyloid, which is what that's looking for. If the MRI is abnormal, then this is what we see on MRI, that's normal, and you get build-up of the amyloid in the muscle, and at some point it all lights up, and it's very, very difficult to clear the tracer from the heart. The measures we use, these are measures of the heart expansion, which is T1, and the extracellular volume, and the MRI produces these beautiful, pretty pictures, essentially, and it's a way of tracking what's happening. But with, which one is it? These are the abnormal ones. The heart muscle's thick. I think this is the T1 and the extracellular volume, and the green is where it's expanded. So enough of the pretty pictures. But anyway, so yeah, if your MRI is normal, you don't have amyloid, so you look for another diagnosis. If the MRI is abnormal, that's where you may need to have a sample taken to confirm the diagnosis. Your light chains are abnormal, your echo's abnormal, your MRI's abnormal. You need a biopsy to show whether you've got amyloid in the heart and what type it is. And then the next step, if you do have to do a biopsy, where can you take one from? With TTR amyloid, you can take an aspirate from the tummy wall, from the fat there, and you can go searching for amyloid there. But unfortunately for wild type 1, which is really what we're talking about, you don't find it very often. It's of low yield, so ultimately if you want to show someone's got amyloid in the heart, you take a little piece of heart muscle and that'll confirm or refute the diagnosis. A fat pad aspirate's much, much better for AL amyloid, which is what Rajiv's going to talk about. So now we've hopefully got the diagnosis, it's really important to get gene testing done. Now, this is one of the good things we have here. I can just fill out a form and access this. And it's funded, we don't have to worry about cost, but over in Oz, this isn't funded on their kind of their medical reimbursement scheme, and you have to pay for it yourself. But we just fill out a form and it gets, like magic, it gets done. For most people, virtually all the people I see with TTR amyloid, the gene test is negative. And the only we're doing it to prove you've got wild type and to make sure you can't pass it on to children. So that's why we do the gene test. If you've had one done, it takes about 4 to 6 weeks to come back. It has a disclaimer saying none of the known identifying ones, but it means you've got wild type, and it's non-hereditary. you're really looking to see if you can find a genetic explanation, because that's relevant for families, and it guides us to how people present as well. But like I said, in Afro-Caribbean folks, about 3 or 4% of them have it. I'll skip through that one. And then, so we've got the diagnosis at last. I don't know how long I've spent talking about getting the diagnosis. Right, I'll speed up. So what treatments have we got? Our aim of treatment is to maintain quality of life. And there's always non-pharmacological things we do first. There's keeping an eye on your fluid and salt intake. Now, I don't really believe in fluid restriction. You only run into problems if you drink 4 or 5 litres a day. That's too much. Most people can drink 1.5 litres, 2 litres of fluid a day, no problem. Be mindful of how much salt you take, though, because salt activates what's called your renin-angiotensin system. That makes you retain fluid. And salt makes you thirsty, so you drink more. So you're retaining fluid, you're drinking more. That can predispose to fluid retention. Regular exercise is an important part of managing any heart condition. I think you're hearing about that tomorrow. It's not going for broke, but it's staying healthy, building up your physical fitness and your resilience. For believers and non-believers, vaccines are important. The flu jab is really the important one. If you get an infection, you're already predisposed to get a bit sicker with it, having a heart problem. You want to protect yourself from that. So it's flu jabs and the COVID vaccine. Looking at nutrition, when you've got a heart problem, you often burn up more energy than other people do. So people will lose weight, and trying to maintain high energy foods is important to maintaining your well-being. And then there's the pharmacological treatment, so the drugs we give out. Now, the hallmark of this condition is fluid retention. People get breathless. You don't need a diuretic unless you're getting swollen. So the diuretics we use are frusemide or bumetanide, and how do we choose between the two? I prefer bumetanide because when you take it, more of it is absorbed into your body in a predictable fashion. So frusemide, your body will absorb anything between 5% and 80% of what you take. So you get, people will increase their frusemide and keep swelling, but with bumetanide, it's about 50% all the time, so it's much more stable. And part of the reason for that is frusemide, when your gut is swollen, you don't absorb drugs so well, but the bumetanide's taken up. And the one we add in is metolazone, and in the kidney, that just blocks urine reabsorption at a different level, so you can often get an extra fluid loss using this one. And you adjust your diuretic dose to try and keep your weight stable and keep you feeling well. So if you're on a diuretic, your weight is stable, checking it every 2 or 3 times a week is reasonable. You're on the right dose. You don't need to do any more. That's good. If your weight is progressively dropping, you're feeling good, cut back, because your kidneys will start to tell you you're losing a bit too much fluid. If the weight is going up, increase the dose. If you don't respond within a day or two, touch base with your doc, because you may need to get it intravenously. There's spironolactone, which is another drug I use routinely. Unfortunately, in about 10 or 15% of males, it can cause sore breast tissue. I know 1 or 2 of you in the room have had this. And you can take eplerenone instead. But at the moment, eplerenone is only available on special authorities, so we use spironolactone as our go-to drug. It works well in combination with bumetanide at getting rid of the extra fluid. But if you're on that, you just have to keep an eye on the potassium. These 2 drugs are called SGLT2 inhibitors. They started as diabetic drugs, but they help if you have amyloid. There's information to say they help keep you out of hospital, they keep the fluid away, and they actually help the heart repair itself a little bit. These are available here. They're available if you've got a reduced ejection fraction, but there's clear evidence that they help if you've got amyloid as well. So I believe everyone who's got TTR amyloid who's needing a diuretic should be on this as well, and most people are. And we think about drugs that may make your symptoms worse. Like I said, your heart is dependent on heart rate to get blood circulating. So if you're on a drug that slows your heart down, you're disadvantaging yourself. And those are the beta blockers, and they're the calcium channel blockers. And these drugs specifically, that's diltiazem and verapamil, bind to amyloid fibrils, so they have more effect in your heart than someone who doesn't have the condition. And over the years, unfortunately, the heart initially is stiff, and the efficiency of the heart does slowly worsen. So that's something we monitor for. And there's all sorts of guidelines about this as to what we should do. I've talked about these, but once the heart function declines, there's other drugs we use. So we use beta blockers if the heart function is not so good, but you don't want to get the heart rate down to 60 because that's too slow. The other drugs we use, the MRAs, the spironolactone, but drugs like ACE inhibitors, so that's the prill drugs, the sartan drugs, or Entresto, they have no benefit if you have TTR amyloid. So they're drugs that shouldn't be continued, and all they do is impact on renal function and can drop your blood pressure without altering what happens over time. And some people have a heart transplant. I just put this in because it's an interesting picture. That's where the heart transplant's been done, and there's no amyloid in the heart. So it cures the heart problem, but this is a really unusual treatment option. This is from the guys in Europe, and you can see over time the amyloid is building up in the other tissues, but it doesn't redevelop in the heart if you have a heart transplant. But that's a very special population. So what can we do to try and help treat or prevent TTR amyloid getting worse? And like we said, it's made in the liver, and there's drugs that work in the liver, and they interfere with your body's generation of TTR amyloid, either by silencing RNA, and these are these two drugs, inotersen and eplontersen. Unfortunately, all the easy-to-pronounce drugs have been taken, so they've come up with all these drugs that are a bit of a mouthful to say and spell. You can replace the liver. These are the small molecule interference ones. There's patisiran, vutrisiran, and nucresiran, which I'll mention in a moment. There's the stabilisers, which help, like I said, the one that binds it together, which is Tafamidis or Acoramidis. This is what's in green tea. There's diflunisal, which is an older anti-inflammatory, which, I don't know if you're old enough to remember Dolobid, but Dolobid was an early painkiller used in the 70s, but it stabilises TTR. And you can try and remove amyloid from the circulation as well. So those are the treatments that we have. Liver transplantation is something that I think is for the past now. It used to be the treatment for amyloid polyneuropathy, but if you do have it in the heart, the amyloid the native liver makes continues to build up in the heart over time, and the heart will get thicker. But the drugs that work inside the liver have superseded that. Now, Tafamidis was the first drug to be shown to be a benefit. This was published in 2018, and what it does is stabilise TTR. So it doesn't get rid of what's there, but it stops things getting worse over time as best you can. And it takes a while for these drugs to actually produce a benefit. You have to be on your stabiliser for a year or two before the difference is apparent in you as an individual. And for you as an individual, the benefit is that you're not feeling worse. So you may notice some improvement in how you feel. It's not curing the problem, but it's delaying change. And that's the important thing when we're treating any of the things we're talking about, bar one. They're not going to necessarily make a big difference in a positive way, but they stop things getting worse. And that's why identifying this early is important, because when you feel well and you're a little bit breathless is the time to have treatment to keep you feeling well rather than if you're getting more limited. And certainly in the European guidelines, it's now recommended that anyone who's symptomatic to a mild degree be on Tafamidis. So Simon was one of the lead investigators in the ATTRwt trial. A few of you in the room have been in the ATTRwt trial and are on Acoramidis, which is another TTR stabiliser. It's now available on the market. I'll come back to the problem with that in a minute. But essentially it has a similar effect to Tafamidis. No one is ever going to compare the two. There's too much money involved. But it delays disease progression. It helps keep you well. And certainly from my perspective, there's some of you that I look after who really are just as well now as 6 years ago when you went into the trial. These drugs really do make a difference. I'll go through that. Diflunisal. Diflunisal is off-label. It's not being used in a trial. Is this your data, Simon? Yeah. There you go. So Simon was a big user. He got me enthused about using this. But it helps delay progression. It's being compared with Tafamidis, and it looks just as good, but it's never going to be used in a trial because this is cheap. and Tafamidis, for those of you who've coughed up for it, is not. So no drug company is going to say, well, the cheaper option is just as good as our gold mine. So no one's going to do that. But it's a drug that certainly globally was being used before the stabilisers were proven in the trials. And I've still got people who take diflunisal, and it seems to be well tolerated and work quite well. Now we're on to the injectables, so we're on to the really clever science. This is, right way around. I think this one's the vutrisiran and things, and this is inotersen, and what you're doing is stopping TTR production. This is the trial that came out. It's on Patro. I know some of you asked about on Patro. Vutrisiran, it helps delay disease progression, and it helps keep people well. It works across all groups with a bigger benefit taken earlier. And if you look down here, I think I've got Tafamidis. Where's the... Yeah, this one. We don't know whether if you're on Tafamidis. If you're not on Tafamidis, it's good to be on this. If you're on Tafamidis, we don't know whether there's an added benefit. It looks like there might be, but there's not enough people on both to say that it's worthwhile if you're self-funding, that spending $750,000 a year is worthwhile for you. You should just choose one and go with the cheaper option because they probably work just as well. And that's the cost if you take both. And that's our biggest challenge. Then we come to the CRISPR gene editing, which Ed is going to talk about. We're running this trial at the moment, wonderful name, Nexigerin, which is called Nexid, which I think is much easier to pronounce. This is switching off production in the liver, and it really knocks down TTR levels. I know some of you in the room have either in the screening process or have received treatment. This is another exciting option because it may be you get a treatment and it stops you producing TTR for 5-10 years. That's something we'll know over time. This came out this week at the European Heart Failure meeting, and it looks to have a similar effect to Tafamidis and to acoramidis. It's stopping people getting worse, maintaining well-being. And this is really cool. So there's some people, I was talking to guys in London, they have patients who naturally get rid of their TTR amyloid. They generate antibodies to it, and they've got 3 or 4 people whose amyloid has been cured naturally. And so there's an antibody that's been generated that can bind to TTR amyloid, and it can remove it from your heart. And the way you do that is on your scans. So you can see here, this is an obvious positive scan, and with treatment over time, the amyloid's virtually gone away. And you've got 2 people that's been seen. It's not gone completely, but if you can remove what's there, that means the heart should be less stiff and it should work better. So this is another really exciting treatment option. We were going to be involved with, what's called a phase 3 trial, the bigger trial with this. But unfortunately, we were all ready to start recruiting, and the drug company pulled the pin here for reasons I won't go into, which was a bit frustrating because essentially the future of this condition is going to be that you get your gene editing treatment, and if you've got lots of amyloid in the heart, you get this treatment, and the problem should be solved and you don't get it back again. But that's in the future. So what's the biggest barrier to treatment? And this is what the real challenge is here. Green tea costs $30 online. So this is current Google prices. Diflunisal in New Zealand, $2,000 a year. You have to self-fund that. Tafamidis in the US at the moment is $225,000 US. And acoramidis, $240,000 US. If you go on their website, Morgan Freeman's on it. So as I was saying to Simon, they had to pay him, and that's why it's so expensive. And Amvuttra, which is the vutrisiran, is nearly $500,000 US a year. And gene editing, I don't know what the TTR one is, but I looked up the first in man that's available. It's $2 million US a year. So this is going to be the challenge locally, is the cost. And why is cost a problem? It's because there's an international agreement. If you have a rare disease, the drug company is allowed to charge a lot to recoup their costs for investigation. But, as hopefully I've said, TTR is not a rare disease. At the moment it's rarely diagnosed, but more and more people are being identified as having it. And we've got, this is what the rare disease cutoff is. And you can see TTR, wild-type TTR, is actually quite common. And it's crossing the threshold where it's not a rare disease. Therefore, costs should come down. How do you make costs come down? You have to prescribe. So we need other countries to be prescribing the drugs to bring the costs down, and then we can jump on board. And to give you an idea, in Australia, Simon was saying there's 100 prescriptions a month? That's 100 new prescriptions a month in Australia, because this has been funded in Oz for about the last 6 to 9 months. Tafamidis has. So hopefully at some point the cost will come down. Increasing awareness is important, but at the moment, I guess with our current kind of austerity approach, this is not going to be easily available for the reasons you can see on the first slide. And also, it's a condition that in 2012, that there was information coming out. It was only in 2018 the first treatment was proven. So it's only the last 7 years there's actually been treatment options. So it's an early time in the evolution of TTR treatments. It's an exciting time because there's lots of treatments coming out and evolving. It's great to be involved with the trials, and Simon has helped get New Zealand involved. The latest one we're hoping to be involved in is going to be using the CRISPR, which is a 6-monthly RNA silencer, which hopefully will tail on to the end of the gene editing trial. What's going on here in terms of treatment? This was local data from Oz and New Zealand from 2022. I bet this has changed from what you've just heard. Across Australia and New Zealand, there really wasn't a lot of people on treatment. There was only 78 people on Tafamidis this is across Brisbane, Sydney, Melbourne, Perth, and Auckland. So that's a tiny number. Now there's 100 a month. These were the people in the trials. Diflunisal, that's Simon plus a few of the rest of us, because we had over 100 people on it. Doxycycline we don't use anymore. And why is it a problem? It takes 4 years to diagnose from the first time people see their doctor. If you're lucky enough to see someone who recognises, looks at your biceps, you're going to get a diagnosis much quicker. That's what all these meetings are about, is increasing awareness. And the problem is the later it's diagnosed, the less good response you have to treatment. And that's more for the cardiologist, what to look for, as we've talked about. And the key thing is education. That's where meetings like this are great, that Jamie's organised. Jamie's been a great advocate for kind of amyloid recognition in New Zealand. There's educational resources out there, like Simon said. The Australian Amyloidosis Network, they've just revamped their website. There's good information there, patient stories as well. The Amyloid Centre in London, the National Amyloid, is one of the internationally leading places. They've got a great website with information as well. And there's guidelines coming out, and this is what I was involved with, the local guidelines for Australia and New Zealand, and we sort of meld in with the other places. And like I said, thanks to the Cardiac Society, because they've agreed to broadcast this. So sharing information is the key thing, increasing awareness so that more people can be diagnosed, and hopefully we can access treatments. Any questions? Yes, it is, and that's where the biopsy is important, because sometimes it looks like one thing, but it may not be. Now, if you follow that pathway we had there, if you've got a thick heart, your light chains are normal, and your bone scan's abnormal, you have TTR amyloid. You don't have AL, and so treatment's targeted at TTR. But if you've got abnormal light chains and your bone scan's abnormal, you can have AL. And that's why taking a sample is important. So you can get, it's unusual to have two disease processes coexisting, but you can do. And that's what the biopsies help clarify. Now, there's other types of amyloid you can get. There's the amyloid fibrils that are linked into, there's an amyloid angiopathy in the brain. you have amyloid fibrils under the microscope, but it's a completely different disease than TTR or AL amyloid, and it predisposes to bleeding in the brain. Yep. And so you've got fragile blood vessels in the brain. In Alzheimer's disease, there's amyloid fibrils seen related to a tau protein, but that's amyloid under a microscope, but it's a different disease process again. So the amyloid is the descriptive phrase for what you see under the microscope. And you're quite right, you can have different types. And that's where the biopsy is so important. And the way we check that is with something called mass spectrometry. So it's looked at under electron microscope and samples are taken, and that's how you get the typing. Type TTR, you can still get neuropathic symptoms, but they tend to be much less predominant than if you've got the genetic variant, neuropathy is not uncommon, and that's what Duncan's going to talk about. So people often have peripheral neuropathy with, like the valine 13 mutation. Neuropathy is quite common with that. So there's different types expressed at different ages. So the neuropathy is more common with genetically determined, and that's where the gene test is so important. So if you don't carry a disease-causing gene, you can still get neuropathy symptoms, but they tend to be less predominant than the cardiac ones. So neuropathy does coexist, but also as the years go by, you get other causes of neuropathy as well that's maybe there to muddy the waters a little bit.
Thank you.
I can tell you what I understand. I think it stabilises TTR to a degree, and it's only been used in it's in an MRI study in Germany, and it was shown that they showed that thickening of the heart didn't progress, and it's only like 20 or 30 people it was used in, so it's not been used widely in clinical trials. But in when there was an absence of any treatments, it's something that there's data to suggest it looks like it stops things getting worse. The dose you need to take is about 400 to 600 milligrams, so it's way above a couple of green teas a day. The major negative to it is it can affect the liver function, so that's what you've got to monitor for. But to go into any trial, you can't be on anything like that. So it's sort of been superseded when you can access treatments by the more modern drugs. Neil.
Tim, a fantastic presentation, and it's really showing us currently the status of the disease. The second thing is the Minister of Finance should be very interested in what you're doing, because if your estimate of 11,000 amyloid people, that's one of the biggest growth industries we've got in the country.
So it's all about, we need to find them, and then you can actually say, well, hey, this is actually a problem. It's not a niche problem. I look after quite a few in the room, but I look after about 40 or 50 people with amyloid. No one else in the country has anywhere near my experience. Unfortunately, the way the system works here, even though Tafamidis is supposed to be one big, everyone can access everything, but there's still the areas. And what I would like to see is that, I can see at least everyone who lives locally. You provide a service. I know some of you come from other places to come and see me, but that's how you grow awareness. But for a lot of people, their cardiologist may see 1-2 cases over 10, 15 years. It's reached a point now where I see 2 or 3 people a week. So it's all about growing experience, and as you grow experience, hopefully. And there's actually the first trainee overseas has got an International Amyloid Society scholarship. So she's spending a year just learning about amyloid, basically. So hopefully she'll come back here and, build on that, and we can sort of grow. But like I say, now, it used to be there was sort of a degree of therapeutic nihilism because there were no treatments. But now there's treatments. That's where driving people to diagnose. And once you diagnose, for us, it's about getting people into trials. Trials give you an option to treatment. And that's where people like Simon help as well, because Simon's been advocating for New Zealand to get trials. And the cool thing with a trial is if you go in a trial, you will get treatment. So both the trials we've had, there was a 2 to 1 chance that 66% of people got the active treatment throughout, but when the trial finishes, you're given the choice of having the active treatment at the end. So it means that you will get treatment. It may be deferred by 2 years, which is not ideal, or 2.5 years, but at the same time, you will get something that works. And as you can see, house in Auckland, amyloid drugs, what are you going to spend your money on? Because that's the ridiculous size of the cost of some of these treatments. They're just prohibitively expensive, and yeah, that's our biggest challenge.
Amyloidosis trials. Is there anything happening in that regard?
There's a lot. Similar to the antibody that Tim mentioned, there are some antibodies looking at trying to remove the amyloid that's already established. Monoclonal antibodies in AL amyloidosis has been somewhat of a boulevard of broken dreams. It's like lots of promise, looked fantastic, but actually when we've done the big trials, it's either been too toxic or ineffective. There are 2 trials that we'll read out later on this year about using antibodies in very advanced cardiac AL disease. So that's good. I'm going to speak about this a bit tomorrow, but I can tell you that there's a lot of trials going on at the moment. There's another one from the drug company AbbVie using a bispecific, which is a bispecific is a monoclonal antibody, again, so it latches onto the amyloid deposit, but all the light chains, and it grabs then an immune cell and brings them together and makes them kiss, and so the immune cell destroys the amyloid deposit or the light chains. So it's really it's extraordinary science. And so we've got the AbbVie trial in Australia, and it's a once-a-month infusion and seems to work very well. The other thing that we know is that in myeloma, about 1 in 8 patients have this mutation in their genes, so part of chromosome 11, which with part of chromosome 14. That's called the 11-14 translocation, and that seems to be very sensitive to a drug called venetoclax. There are new trials that are looking. So it's 1 in 8 in myeloma, but if you've got AL amyloidosis, 50% of people have that mutation. So venetoclax seems to be something that works very well. I can tell you that around the world, there's probably about 20 of us who have been nagging AbbVie to do a trial in AL amyloidosis. For the last 10 years, I've been in multiple discussions with the drug companies trying to get them to do a trial. They've elected not to, which is really annoying, but now we've got other drug companies making similar products, so we're expecting trials to start with that soon. Daratumumab or Velcade, there's lots of different treatments. So the French have done quite a lot of work looking at their experience. We certainly have had, there's a trial in Australia called the VIBA study that's looking at iberdomide, pardon me, which is a lenalidomide type treatment, like a new super lenalidomide with venetoclax and dexamethasone. Some with daratumumab, but I'm probably stealing all of Rajiv's thunder here, so he's probably there in the corner going, will you shut up, I'm going to be talking about all of this. So I should probably stop, and I can see Jamie's looking at a watch going, will you shut up, Simon, as well, so that we can all go and have some morning tea. Is it time? Yeah, okay. So
any more simple questions about TTR, please?
Can I just ask the hereditary testing? Yeah. What's the process about that? How do we get that done?
It's a blood test. So essentially, you just need a blood form, and it's a blood test. You could, they're done in Christchurch, so you just go to your local lab with a blood form that's specifically a Christchurch blood form, and it takes about 4 to 6 weeks, so it's really easy to arrange.
Thank you.
And if your cardiologist needs a form, I can email it to them. Because that's it. Oh no, but you've got to get the pathway going.